Thank you. Good morning and good afternoon, everyone, and thank you for joining us. Before we begin today's presentation, please share with me in acknowledging that today is Orange Shirt Day, the first National Day for Truth and Reconciliation in Canada. Orange Shirt Day is a day to honor the children who went to residential schools. It is based on the story of Phyllis Webstat, who in 1973 entered the St. Joseph Mission Residential School at the age of 6. She was stripped of the orange shirt she was wearing and forced to wear the institutional uniform. This year, September 30th, has been chosen to mark the date when government and church officials would arrive in communities to take children to residential schools. These schools operated in Canada between 1831 and 1996. We're committed to honoring the National Day for Truth and Reconciliation by encouraging everyone to engage in education and encouraging reflection on how individually we can support reconciliation with Indigenous peoples, both today and beyond. And just for that reflection, I'll just take a moment for silent reflection. Thank you for that moment. We at the Canadian Partnership for Tomorrow's Health, or CanPath, are committed to working with leaders of Indigenous organizations and Indigenous people and Indigenous scholars to ensure that we can enable research that meets the needs and interests of Canada's Indigenous people and communities. Also, I'd like to acknowledge that the land on which the CanPath Coordinating Center here at the University of Toronto operates on land which for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, together with CanPath teams across Canada from coast to coast, we are grateful for the opportunity to work on lands that are the home to many Indigenous peoples from across Turtle Island. And now to introduce today's webinar, my name is John McLaughlin. I am a professor of epidemiology at the Dalla School of Public Health at the University of Toronto and the executive director of CanPath. Welcome and thank you for joining. The seminar today is entitled The Canadian Network for Advanced Interdisciplinary Methods, CanAIM, in Comparative Effectiveness Research. There are a couple of small housekeeping items first. We have time for questions during the Q&A following the discussion or following the presentation. And to ask a question, please use the Q&A button at the bottom of the Zoom window and type it in. If we don't get to answer your question today, please connect with us by email. The email address is info@canpath.ca, which we'll share again later. We also invite you to connect with us on Twitter at the handle @WeAreCanPath or LinkedIn as CanPath. Our speakers today are Dr. Cristiano Moura and Dr. Sasha Bernatsky. Dr. Moura is a research associate in the Center for Outcomes Research and Evaluation and the Division of Clinical Epidemiology at the Research Institute of McGill University Health Center and a longtime CanAIM investigator. He has an interdisciplinary research background in epidemiology, pharmaceutical sciences, health informatics, and public health. Cristiano has authored many peer-reviewed papers on drug safety and effectiveness projects in many disease areas. Following Dr. Moura will be Dr. Bernatsky, who is the James McGill Professor of Medicine and nominated PI of CanAIM. This national team provides novel and accurate data on long-term real-world outcomes related to drug therapies for the Drug Safety and Effectiveness Research Network, a joint initiative between the CIHR and Health Canada. Working closely with Health Canada's Marketed Health Products Directorate and other knowledge users, CanAIM produces highly relevant and timely studies of a wide range of high-priority drug safety and effectiveness topics. CanAIM also provides career advancement opportunities for graduate and postgraduate students. Through its vision and leadership, CanAIM is making essential contributions to building research and capacity and forming future experts and leaders in drug safety and effectiveness research in Canada. And so with that, I really am delighted to have both of you speaking with us today, and I'll turn it over to Dr. Moura first. So thank you.
Actually, I'll be going first, but perfect. Thank you for that perfect introduction. So CanAIM is a small acronym for a large title, but that's who we are. And as John emphasized, we're all about drug safety and effectiveness research, and especially the training of highly qualified personnel. So to start off with, we thought we'd put just a very small poll up to find out what the experience is of the participants today regarding drug safety and effectiveness research. So the questions are, have you used or are you using CanPath data for research? If so, have you used CanPath self-reported drug information? Have you used CanPath data with linked administrative health data? So you can go ahead and vote. Okay, so I guess we'll review the answers to that poll at the end, but the questions we're going to answer today are: why study drug safety and effectiveness? What is DSEN? Who is CanAIM? And how is CanPath helping provide answers for regulators regarding optimizing medication-related outcomes in Canada? And what challenges do we face when using CanPath and other secondary data sources to study drug safety and effectiveness? So Cristiano will be spending some time talking about drug exposure, getting it right, that very important exposure, and giving you some examples from real projects. So we can go on to the next slide. Why study drug safety and effectiveness? Well, as many of you may know, public drug spending is huge in Canada, over 15 billion in 2019, according to CIHI's website. And even more importantly than cost, in my opinion, is that every year in Canada, there are up to 200,000 severe adverse drug reactions. And the impact of this includes the death of almost 22,000 Canadians. As a physician, the thought that even one person could die because of a drug that we as physicians prescribe is really troubling. And in addition to that, of course, there's the cost that these adverse drug reactions cost in terms of hospitalization. So I think it's not an exaggeration to say that all of us are affected by drug safety and effectiveness issues at some point in our lives, be that ourselves or a loved one. Next slide, please. DSEN, the Drug Safety and Effectiveness Network, was established over a decade ago by CIHR in collaboration with Health Canada and other stakeholders, including the provinces. And the goals were to improve the evidence for regulators on drug safety and effectiveness, to enhance the capacity within Canada for high quality post-market research on drug safety and effectiveness. So that's a theme that we'll come back to time and time again. Up to the present, DSEN was hosted at CIHR, but in the coming year, there'll be a DSEN 2.0 version where the role of CIHR will be taken up by the Canadian Agency for Drugs and Technologies in Health, or CADTH. Next slide, please. So this shows you on the right-hand side a bit of the structure behind DSEN originally, where we have the DSEN coordinating office hosted at CIHR and the 4 teams. Initially there were 5, but Search merged with Search Prevent. So we've got MAGIC, which is a team that does systematic reviews, CNODES, which uses primarily administrative data to look often at safety signals, and CanAIM, which has the mandate of using real-life cohort data to look at drug safety and effectiveness. And how is it decided which drug safety and effectiveness questions get focused on? Well, it begins with Health Canada or another formulary body or another agency posing a question, bringing this to the DSEN coordinating office, who then bring that query, as we call it, to the teams for discussion, and we all determine if our methods are a good fit for the query. It may be more than one team that gets assigned the responsibility of working on a given query. But there has been an ongoing discussion at monthly scientific advisory committee meetings where there's the team representatives along with Health Canada and other individuals discussing the queries, and then after some feedback and some thought, Health Canada or the query initiator will then decide whether or not to proceed with that project. So we can go into the next slide. CanAIM's mission then is to be focused on real-world drug safety and effectiveness using often clinical cohorts. But there are challenges anytime you use observational data to try to look at associations between a given exposure and an outcome. So with observational data, we have non-random allocation, and we know that, sorry, if you could just go back to the other slide. Thank you. So we know that non-random allocation also is associated with non-random allocation of potential confounders. So that's one set of challenges. Another is drug exposure definitions. When we're thinking about diseases that are often chronic for years and associated with very complex therapeutic strategies that may include changing doses, changing drug combinations. And finally, sometimes the outcome ascertainment can be challenged by various issues, including interval censored data, which means that an individual will be only assessed at periodic episodes for the outcome of interest. So for all of these challenges, we as a team have tried to employ sophisticated analytic methods to avoid sources of bias. I'll mention also in our mission again, we are focused on vulnerable populations, including drug exposures during pregnancy, which is a very important domain of our research, one that is headed by Anik Berard. And that again, to emphasize that we're a team for whom it's very important to build and enhance capacity for this kind of research in Canada. So we're a national team, as you can see by our on this map. Next slide, please. So we've been around, CanAIM has been around for about a decade, and in that time we have successfully completed or in the midst of completing over 20 projects. So I mentioned CIHI's website. There you'll find the top 3 drug classes in terms of expenditures in public health spending for drugs, and these include diseases like rheumatoid arthritis, age-related macular degeneration, and hepatitis C. And these are all projects that CanAIM has been able to contribute to throughout its mandate so far. So I mentioned some of our focuses on vulnerable populations, particularly during pregnancy. I'll mention we have a really innovative 5-year project underway, gathering data for Canadian patients who are exposed to biooriginators versus biosimilars. So a really important effort to establish the role of biosimilars in terms of ensuring that Canadian patients have a good care at an optimized cost. And then finally, in the past year, we've been working very hard on some COVID-related queries. Next slide, please. So now I am going to turn it over to Cristiano, who is going to take you through some...
I guess this is my turn now. Thank you, Sasha. I've been talking a bit about drug exposure, how we define drug exposure in pharmacoepidemiology. We thought that would be interesting to have a preview or a brief explanation of the different ways we can define drug exposure in pharmacoepidemiology, but this by any means intend to be a deep review on the topic. because there are, of course, many aspects that should be considered. Next slide, please. So I'd say that in drug exposure in pharmacoepidemiology research, the scope is to quantify the association between a drug exposure and the health outcome in general. This is what we do in different projects. And sometimes we are able to test causal relationship between the drug. So in pharmacoepidemiology, drugs are actually the main exposure. And if you think any epidemiologic investigation there, where you have exposure and outcomes, a drug is the main exposure in pharmacoepidemiology. Next, please. So next, okay, thanks. I guess one way to relate that with, I'm assuming there is a variety of background here in terms of how do we use drug information in different aspects. I thought it would be interesting to contrast that with a well-known design, which is a randomized controlled trial. This is in a way where we get, and for some it's considered standard code, where we get where you can investigate the effect or compare the effect between two drugs. So represented here in the left side of this figure, an important aspect that contrasts with observational study, which is the other type of study that you can also use drug as main exposure, is that in RCT, we have a random allocation of the drug, while in observational study, this occurs by natural allocation, meaning that people with physicians decide, patients and physicians, and the circumstances of drug access, decide in that sense who is going to take which drug. So that small difference represented here means a lot in terms of how we treat both situations. I know there are complexity involved in RCT, but there are also many aspects that you should consider and when you do natural allocation and you follow patients from real world. One of these aspects is the one that I want to treat in the next slide, is that people could, and real world, they can stop treatment, change treatment, switch treatment between drugs being studied, use different doses. So there is no standard way that you can have drug use. Next slide, please. So when considering how we model drug exposure on observational pharmacoepi studies, you can think of a simple approach, which is just we call time-fixed exposure, defined if people are using the drug, then they are exposed, or if they never use the drug, then they are not exposed. You can think about an example with anti-inflammatories, NSAID, that people could take that for a short period of time. They could be long-term users, and all this, and ever versus never approach is treated as, in that sense, equal for the what you modeling. So a different approach would be to consider that medication used longitudinally, it would have interruption in use by patients. Patients could switch treatment, they can switch dose. And one way to deal with that is treat the drug exposure as time and varying exposure. On that representation on the right side, you can see that a patient, a given patient could use drug for a while, then interrupt and then resume the drug again. And this is modeled in different ways as current versus non-current use. Okay, next slide. Okay, so we talked a bit about how model drug exposure, and but how we get that information from real world. So one possible way is doing linkage, but I'm going to explain in the next slide. So if you think and real world data derived from study cohorts like CanPath, where people were assessed at intervals, and that during this during this survey, they are asking questions about the drug use, use of environmental exposure, use of healthcare services, and then a lot of other things. And you think that this is a assessment that is done, and each time you do that, there are a lot of effort and resource involved and expand on that. So it's usually between surveys, it takes time because you need to put all that effort together to get that information. And from what we saw in the previous slide, it's expected that some information, especially on the topic here, drug exposure, could be missing. So one key aspect to optimize CanPath or study cohorts like that for drug safety and effectiveness research is to link that that cohort with administrative health data, for example, where you can get drug dispensation and other things. So by doing that, we could create or construct a longitudinal history of drug use, past use, current use, and drugs that were interrupted at some period, for example, between assessments. Next slide, please. So luckily, we had the opportunity with CanPath to link participants with health data, since they provide consent to follow up through linkage with the administrative health database. And by doing that, we are able to link and to obtain several data on use of healthcare system, physician visits, and especially drug use and other things that we can consider as outcome. So our team, together working with CanPath and different cohorts, participants in CanPath, we went through some process of linkage of data, and by doing so, we obtain more robust information on drug use. Next slide, please. So in the 3 slides, I'm just describing what we've done with 3 of the cohorts, a participant cohort in CanPath, Cartagena, OHS in Ontario, BC Generation Project in BC. So for Cartagena, Cartagena was the first cohort, CanPath cohort we worked with, and we linked that the first wave was around 20,000 participants, and together with the second wave, we got more than 43,000 participants that were linked with administrative data in Quebec. And first, we linked this with data from 1998, which is before the first CanPath assessment, and up to 2015, and more recent to 2021. So what type of data we got? We got things like if those people visit physician or were hospitalized during this period for the different database. This comes from the Régie des Soins Maladie du Québec, REMIQ database that has information on physician services, but in also pharmaceutical services that include drugs dispensed in Quebec. We also get data on hospital stays, diagnosis during the hospitalization, and the death data. Next, please. We did the same process with OHS, that represented more than 225,000 participants that were linked from data from 2006 to 2016. And we have a more up-to-date refresh of the data that goes up to 2020. Again, by this linkage, we get data on discharge abstracted, hospitalization, and cancer registry, and of course, Ontario drug benefit that provide data on drug dispensed in Ontario. Next, and finally, BC Generation Project, the same process with 30,000 participants that were linked with population data BC. And this is also provided through PharmaNet data on medication and other vital statistics and physician visits, again, with and data on hospitalization. So all these three large database linked with administrative data provide us the opportunity to study in more deeper way how drug being used by this population. Okay, next. So now we're going to talk a bit about different ways that CanPath can be used for drug safety and effectiveness research. As you know, CanPath has assessed drug exposure at the survey, at the baseline survey by self-reporting. So participants would be there and report the drug they were taking at the moment of the survey. Using that information, we could conduct a single point drug exposure without using linkage on the with cartridge data in the on project and hypertension. Another aspect that was it's also important in this is by using linkage was the agreement between what was reported by participants on drug use and what was recorded on the claim data. That was also done with Cartagena. And the one that I would spend a bit more time is in the three cohort that I just described, we were able to, using linked data, to get patterns of drug use, and that was illustrated with a class of drug called AG2 blockers. And we have now an ongoing project that we are investigating the association between some class of hypertensive agents and risk of non-melanoma skin cancer. Next slide, please. So this was a study that we did back in 2018, 16, and the objective was to describe the association between current antihypertensive use and measurements of central blood pressure. And the reason for that was that thiazide diuretics, which is a class of antihypertensive that's been used for a long time, there was some question if that for patients with non-complicated hypertension, they would perform how they would perform compared to other drugs, other class of more modern antihypertensive agents. Next slide, please. So what we did, we took the first data from the Cartagena first wave, 20,000 participants, and selected hypertensive non-diabetic participant that was obtained by self-report. Remember that at this point, we're talking only on CanPath data alone, not linked. And based on the drug self-reported, we classified patients on monotherapy as one of the four groups, including thiazide diuretics, but also calcium channel blockers, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers. So what we did is we took the measurements that were performed in Cartagena, both peripheral central measurements of blood pressure and related with drug exposure in the multivariable linear models, where we compare TD versus the other types of antihypertensives. Next. So what we found was that GD monotherapy was not associated with either statistically or clinically significant high levels of either peripheral blood pressure or central blood pressure measurement when compared to other monotherapy of other antihypertensive class. These findings are important because, as I said, the GD is a large, for a long time used antihypertensive drug, inexpensive compared to the others, and it was important to reassure they all as equivalent to other more recent antihypertensive drugs and dealing with non-complicated hypertension patients. Next. Here's another example how we used, this time was also with Cartagena, but this time we used the linked data, and the objective was to describe the agreement between that was medication that was self-reported by participants and what we found in the claim prescription record. This is very important because there are a larger amount of people, patients that don't take drugs as prescribed, and many also take drugs and OTC. So when you're considering, look at the information that you have on claim data, you have to take this in consideration. We also investigated factors that could be associated with poor or good agreement between the two data sources. Next. Okay, so how we did that? We took self-reported medication data that was obtained from Cartagena. And this was based on the original question, are you currently taking any prescribed medication? This is a question that's important because that frames the time that we're looking at the claim data. So we took data from RAMIQ dispensation database. And this database, as referred before, would contain data on outpatient prescribed medication, including name and dose. And then we compare our medication reported by Cartagena participants and that described on the claim data. And we did that in a 9-day period. We tried different timing windows in sensitivity analysis just to see if that assumption holds. Next. And what we found on this was that we found that the agreement that the agreement between self-reported medication and data from the administrative data varied, depend on the medication class that you are considered. In general, if the medication are taken chronically, it's more likely that it will have a good agreement with what was reported and then what is within the database. We found some factors, depending on the class, drug class being considered, such as female sex was associated with low agreement. More important, high number of reported medication. When patients report a high number of medication, and that makes sense because they can miss, if they are taking several drugs, they can miss some of them during the survey, and that was also a factor associated with some low agreement. Next. Okay, so the third and last example of how we used CanPath linked with administrative data was to describe prescription patterns of ranitidine in Canada. This was, you can move next, please. This was originally a Health Canada question, query, because these drugs that are used to treat gastric reflux, acid ulcers, and the most available over the counter. There were new safety concerns about if back in 2019 about some detection of some contamination with a carcinogen agents in some batch of that drug. So Health Canada would be interested in knowing what was the patterns of use of these drugs and different populations. So we thought that would be a good opportunity to use CanPath linked data on that project. So next. So our objective was to describe prescription patterns of ranitidine, disetidine, famotidine, and cimetidine, all H2 blockers in Canada. For that, we select individuals from 3 CanPath cohorts ever exposed to ranitidine or these drugs or the H2 blockers. And of course, because we're using a drug that were derived from drug information that were derived from administrative data, we restrict the analysis of those individuals that were covered by the public provincial drug programs. Next, please. So we start the follow-up on this to describe this use based on the first dispensation of one of these drugs. Then the whole history of dispensation during the observation period was used to create periods of use and to describe periods of non-use for those patients initiating these drugs. Because individuals can stop treatment and resume treatment at any point, we allow individuals to contribute with multiple periods of use, with whatever period of use ending when there was no more dispensation for that drug. And we treat things like overlapping periods of between dispensation. This is important when we want to use drug data from claim data to actually describe real world use of that drug by patients. So what we found sometimes in the drug claim data is not exactly a perfect use that a prescription ends here and the next prescription start next day. Sometimes there are overlapping because this is how life is. People can pass by the pharmacy early to get the prescription. There are different reasons that create overlapping between periods of use. So we have to come up with some definitions on how we consider that that's a new period of use. And when we stop that, people could also switch doses, and that was also considering in our analysis, all that to create a description of use of this drug by these patients. Next. So the analysis was, first we did some baseline description of the participants, and then we describe pattern of use in different ways, consider the observed periods since the first prescription, number of periods of interrupted use during the follow-up, what was the cumulative duration of use in days, cumulative duration and doses, and there is this standard definition of defined daily dose that you transform any drug dose in the standard measurement called DDD that we then can compare drugs that are within the same class, but different drugs in the same class. Okay. As I said, because we have to do some assumption on how people use drugs, because of that, we also do some sensitivity analysis based on varying a bit those definitions. I'm not going to do this. It's just to show you that we have to be aware of these variations and what our assumption would impact the results. So things like assuming that there was a interruption because there was a gap between prescriptions, and we allowed certain period of time to be considered the patient is still on drug, all different things. Okay, next, thanks. So in terms of results, it's here baseline characteristic of the 3 cohorts. We selected 3,500 individuals and users of these drugs and OHS. A majority, not only in OHS, but in all cohorts, were use of ranitidine. This is not surprise. Ranitidine is by large the most used H2 blocker on this population. We have a variety of distribution of sex use, most of world human, in the three database, and an average of date, age. On that, we should consider some aspect of public, different provinces have different policies for coverage of drugs, so that also impact this baseline characteristics. Next, please. So here's just one example. We did the same thing with a Carthagene cohort and BC cohort. Since the results are pretty much similar, we decided just to show what we found in OHS. This was when we constructed since the cohort enrollment, and then we look at how was the drug used in the first year, since the first prescription to the end of the first year, and how was the entire period of use since the first prescription till the end of follow-up for any reason. And what we found is that there was 1.9 period of use in the first year, or 3.4 periods of use when you consider the entire follow-up. That means an average people would, in the first year, would stop using the drug, be away for a while, and then resume the drug. And average that would happen 2 times in the first year, and 3.5 in during the entire follow-up. There was about 141 days of use with 133 DDDs. Using DDD as a measurement of what is the usual dose per day, we could say that hopefully this represent 1 DDD per day. People would be using the drug at what is the standard values. We saw that also for the entire period of use, 384 days with 361 DDD. And each period of use lasts for 110 days on the entire follow-up with 104 DDDs during that period. So next slide. As I said, we did this for the other two cohorts, and results were similar. So we jumped directly to the conclusion. First of all, this is an important describing patterns of drug use for regulators. It's feasible using CanPath data, and in the way that we showed, link it. And this is illustrate a great use of how we can use the linked drug data. Talking about specifically the results in all 3 cohorts, ranitidine was the H2 blocker most larger used by participants. Participants were intermittent users of these drugs. That means that they intercalate periods of use and non-use. Those were mostly within the recommended dose, and all this information has been reported back to Health Canada for the use. Next slide. So there are some potential limitations, as you can imagine, from this type of analysis when we do linked. The results that we show is linked data that we were only able to study on those that have provincial drug benefits. Example, in Ontario, that would be restricted to seniors. And we have no data from private sectors. Also that this analysis was restricted to prescribed medication and does not include over-the-counter drugs. One question that we could have for the future it could be that we could use self-reported CanPath medication that could help address some of these points, this potential limitation. Okay, next. Okay, so in summary, as Sasha pointed out at the beginning, we are affected by drug safety and effectiveness at some point or during our lives. CanPath data can be used to help regulators regarding optimizing medication-related outcomes in Canada. However, there are many challenges we just touched, and some of them when you use CanPath and other secondary data source to study drug safety and effectiveness. This highlights the importance of DSEN team, like our Canadian team, to thoughtfully consider potential limitations of data and use best practices in attempt to overcome this limitation. And finally, building an enhanced capacity, women trainees and high qualified personnel is the key to ensuring that Canada continues to be a leader in drug safety and effectiveness research. Okay, thank you.
Thank you very much for those excellent presentations. And we can switch now to, we have 10 minutes left for 12 minutes left for questions. And let's open the floor to that. There are some that have been posted here. One that was there was a question earlier that's been answered online that people can see that Dr. Bernatsky has answered with regard to the collaboration with only academic institutes. And so she has addressed that partly. I can also add that CanPath itself has largely been used by university-based researchers, such as in today's presentation, but that with our partners across all of Canada, in each of the provinces, we've been able to establish a policy that does allow CanPath to work also with the pharmaceutical companies and industry. It's very helpful to have leaders in the field, such as Dr. Moura and Dr. Bernatsky, drive that science. But in the same way that real-world evidence that has been presented today is of interest academically, it's also of great interest to regulators, as Dr. Moura has described, and then also of increasing interest to pharmaceutical companies. So I think that's an important point. There's another question here. Thank you for the webinar. As a pharmacist, I really enjoyed the topic of this webinar. In addition to the studies mentioned in this webinar, I wonder about the potential of using CanPath-rich data sets in future pharmacoepidemiologic studies. Did any CanPath cohort regions currently consider conducting such type of study? I mean, given the close experience that our guest speakers today have had, can you comment? I could follow up a bit about CanPath itself.
Well, I'll say the DSEN-wide procedures have always looked to a regulator or a decision maker to come up with a question that was of primary relevance. Especially one of we didn't emphasize this, but one of the considerations is always timeliness. So DSEN arose because there was this understanding that policymakers needed results within a very short time period. So all of our projects, or most of our projects all of our projects have deliverables within months. And most times we're trying to answer the query within a year, which as academics, this is a very short timeline. I think for most of us who are used to having projects span 3 years or 5 years or longer sometimes. And so in terms of regional specific endeavors, I think that moving into this, I mentioned there's a version 2.0 of DSEN, which will be housed at or hosted at CADIT. We are really hoping across DSEN, and certainly among CanPath, among Canning, that there will be increasing involvement of provincial decision makers. So there will always, I think, be an important element of working with directorates like the Marketed Health Products Directorate at Health Canada, but it would be nice also to stay really linked into the provincial formulary bodies who also have important questions around drug safety and effectiveness.
Thank you. I can add a little bit further from the CanPath perspective to what Dr. Bernatsky said. I also note that the question came from a person working on the Manitoba Tomorrow project, which is actually in recruitment phase now, and I'm pleased to report that recently we've been able to add Saskatchewan. So that means that every single province is going to be included in the CanPath data sets in the future. So I also note that a province like Manitoba is a really excellent place for record linkage types of work to be done. And in the future, the type of work that you've presented today could also be done in other provinces. I can ask one question. Oh, there's another one that's come from Saskatchewan. The question from Riaz Alvi is, as we build the cohort in Saskatchewan, we are exploring linkage to our cancer pharmaceutical data, which is in-house in the Saskatchewan Cancer Agency. That's the host of agency for the cohort in CanPath, so in Saskatchewan. So I think that's more of an observation, but I think it's an example of how the consents that the participants have given does enable record linkage to either clinical or health systems databases, and those linkages are extremely important. I could ask a question of the speakers. So one of the things I commend you for in doing is that this is really the first, your work is the first demonstration of the use of a large pan-Canadian cohort for the purposes of the real world evidence about drug usage and patterns in the real world. So would you have any suggestions about how further we could do this better in Canada? And I ask it in the context that CanPath itself is at a renewal phase, and we're trying to describe to the federal government that this type of platform is useful now, and it actually only gets more useful with longer follow-up and larger numbers of participants. So would you have any suggestions or recommendations for either the federal agencies or for messages that we could take to them?
Definitely. Perhaps it's a very, perhaps it's perfect timing in that with movement to CADIT, perhaps there could be some formalization of links between teams like ours, CanAIM and CanPath. I think that some of the important drug safety and effectiveness questions are really enduring, and I've long advocated, for example, that DSEN could have ongoing projects related to new diabetic therapies or new hypertension therapies, because there are always going to be drug safety and effectiveness questions around those areas. So that would definitely be one thing. And the other thing would be perhaps, I mean, I'm always advocating opportunities to develop capacity. And I think we have to remember it's not just about producing pharmacoepidemiologists, it's also about having other kinds of researchers understanding the limitations and potentials of the data that they work with. So CanPath as an organization has all kinds of different researchers and scientists, not just, perhaps Cristiano and I came to you to offer our interest and experience with pharmacoepidemiology. So we would like to continue to provide a link that will help explore opportunities. I think we always have to be aware, not just of the opportunities, but the limitations, so that whatever end products are really useful to the people who need them.
Thank you. Cristiano, would you have any other advice for the federal agencies or myself?
Yeah, I would essentially echo what Sasha said about collaboration. I think this is important, and given what we showed today, a bit about the complexity of studying drugs, when you have this opportunity with research for different areas together and linked by CanPath, it's an opportunity to exchange methods, and wherever people are interested in the other domain, but they're using CanPath data, but some reason they also want to use drug use data, it's important to have that linked with people with experience on that area. I would say the other way is also valid. So yeah, I guess this is
Thank you. I might have anticipated one thing you would have suggested to us, but part of the reason why I commend the work that you've done so much is that I know it wasn't easy because it had never been done before. There was a lot of groundwork necessary to actually get it started, build it, demonstrate the value. And that included having to go essentially to one region at a time and help the region figure that out. So I'm pleased to be able to report that now that CanPath has a scientific home base at the University of Toronto, and we've been able to drive some of the whole country's thinking, that we've been able to work with agencies where the data will come together into one central place so that a research group like yours could actually go to the national harmonized data set, even including the drug usage and the linked data. It's a work in progress, but one of the areas of pilot work in a place underway right now is with the Canadian Institute for Health Information, which allows linkages to be done in a systematic way for all provinces that they have access to those data for. They have analyzed our consents for the consents for each region, and are now able to provide a national linkage to at least some of the data sets that they have. Some people would know about the discharge abstracts data and the national ambulatory care data. So that's fantastic. You know, hopefully that'll make the work of pharmacoepidemiologists like yourself easier in the future, but there's still a role for the more detailed dive into the drug usage data that you quite correctly went to the individual provinces for. I see another follow-up from Noor in Manitoba is basically acknowledging further that the College of Pharmacies at the University of Manitoba is now focusing on pharmacoepidemiologic studies, and there is great potential. I think great collaboration, especially as the Manitoba project becomes larger over the coming year or so. With regard to pharmacoepidemiology, and I think it is of tremendous interest to the regulators, can you see in the future of this type of work analyses that would take advantage of the biospecimens that have been banked or the genomic information that is being collected? And today that didn't come up in your presentation, but in the future of pharmacoepi, do you think biological markers will be part of that that type of assessment that will be of interest to regulators?
There are so many ways it could be. And in fact, I've also used CanPath and other analyses where we've looked at biological markers. So I'm a rheumatologist. So in other projects, I've actually looked at serological markers of disease, some of the interesting and intricate rheumatic diseases that are characterized by really specific patterns of autoantibodies. So that's one example of something I've already took advantage of, but there are so many more. So we didn't stress this, but the concept of having linked clinical and administrative data really makes the most of all that detailed administrative data, plus the richness of not only clinical data, but the biospecimens. So we're really excited about opportunities with CanPath.
Thank you. I see that we've reached our time, but thank you to all of the participants, and please share with me in commending the great work of Dr. Moura and Dr. Bernatsky. I look forward to seeing this progress further, and I think you've sparked a lot of interest across the country. And if there's any other question, please feel free to send them to us at CanPath. So again, applause to our speakers, and we wish you well.
Thanks. I put my email in the chat box if anybody wants to contact me. Have a good day.
Thank you. Most helpful.
Thank you.
Thank you. Bye-bye.